Treatment of FGF23-mediated hypophosphatemia in children and adults with fibrous dysplasia. Here are my disclosures. I also want to point out that all of the results from this trial are available in preprint form on medRxiv and will hopefully be available soon in a peer-reviewed journal. So fibrous dysplasia at its essence is a disorder of soft bones. Most of the complications of FD arise because the skeleton is structurally weak and doesn't hold up under weight-bearing forces. We see this result in bowing deformities in the long bones, which can affect both the upper and lower extremities. We see this in the spine with scoliosis, and we also see this in the craniofacial skeleton, which in some patients can cause the skull base to enfold around the top of the spine, which is a complication called basilar invagination. FD bone is weak because it's abnormally formed and poorly mineralized. G-alpha-S activation disrupts differentiation of skeletal stem cells, leading them to form osteoblast-like cells. The resulting skeleton is comprised primarily of expansile fibrous tissue. When the cells are able to make bone, it's structurally abnormal, as you can see here with all of this disorganized woven bone. And it's also intrinsically poorly mineralized, as you can see here from the prominent red areas of unmineralized osteoid. At its essence, FD is a benign skeletal neoplasm, and FD cells produce FGF23 as part of a paraneoplastic process. The amount of FGF23 that they produce is relatively low, so we typically only see frank hypophosphatemia in patients that have a high burden of FD. However, because FD bone is so abnormally formed and poorly mineralized, it's at high risk for adverse effects of hypophosphatemia. Here we see data from our NIH natural history study. Note that patients who have either frankly low phosphate levels or low normal phosphate levels in the bottom quartile of the age and sex-adjusted normal range have higher complication rates than patients with high normal phosphate levels. This suggests that patients with FD may have clinical benefits from maintaining phosphate levels at the upper part of the normal range. To test this, we performed a phase 2 trial of Burosumab in patients with FD. Burosumab is an FGF23 antibody approved for treatment of the FGF23 excess disorders, X-linked hypophosphatemia, and tumor-induced osteomalacia. This was a single-center study conducted at the NIH Clinical Center. We enrolled both children and adults. The primary endpoint was the proportion of patients who achieved a high normal phosphate level at week 48. This was defined as an age and sex-adjusted Z-score between -1 and +2, a target that was based on the natural history data I just showed. Safety endpoints included effects on lesion activity. We wanted to ensure that FGF23 blockade did not exacerbate the activity of neoplastic cells, and we evaluated this using functional imaging scans of sodium fluoride PET-CT and in pre- and post-treatment FD lesion biopsies in adults. We used the standard starting doses and titration intervals that were developed for treatment of XLH and TIO. In standard dosing, children are dosed every 2 weeks and adults are dosed every 4 weeks. We also included the option to increase dosing intervals in adults to every 2 weeks if needed. Here you see the baseline demographics. I wanted to highlight that, as expected, this was a cohort of patients with an overall high skeletal burden of FD and a substantial degree of disability. 8 of the 12 patients required full-time ambulation aids, including wheelchairs, walkers, or crutches. I also want to highlight that 3 of the adult patients were receiving concomitant treatment with denosumab, which reflects typical treatment practices in FD. Here you see representative clinical images of the trial patients at baseline. This photograph on the left shows a 17-year-old patient with a panostotic FD. He has severe scoliosis resulting in a shortened trunk. He has never ambulated, and you can see muscle wasting and contractures in his upper and lower extremities. The next image is a humerus radiograph from an adult patient, which highlights that the bowing deformities in FD can commonly affect both the lower and upper extremities in severely affected patients. On the right side, we see 2 sodium fluoride PET-CT scans, which demonstrate the spectrum of fibrous dysplasia involvement in the trial cohort. So the individual on the left was the most mildly affected with a skeletal burden score of 28, indicating that about a third of her skeleton was involved. At the other end of the spectrum, we had 3 patients who had panostotic FD, indicating total skeletal FD involvement. Burosumab corrected phosphate levels into the target range in all 12 patients. In the left panel, you see age and sex-adjusted Z-scores with the target range indicated by the dashed box. The right panel shows changes in the raw phosphate levels. Burosumab treatment led to a substantial reduction in alkaline phosphatase levels. Alkaline phosphatase is a serum marker of bone formation, and recall that FD is a disorder of bone-forming cells. Alkaline phosphatase levels are therefore typically elevated in FD, and they are generally used as a gauge of lesion activity. In general, alkaline phosphatase levels don't tend to reliably decline when patients with FD are treated with conventional therapy for hypophosphatemia. However, in this study, alkaline phosphatase levels declined by an average of 49%. This was surprising to us and suggests that hypophosphatemia contributes to a larger component of the elevated bone turnover in patients with FD than we previously recognized. Consistent with these findings, Burosumab also improved other pharmacodynamic measures of FGF23 excess. This included an increase in both 1,25 vitamin D and TMP-GFR, measures that are both typically lowered by FGF23 excess. These findings confirmed that Burosumab normalized overall phosphate homeostasis in our patients, which led to the improvements that we saw in serum phosphate levels. Our study was not powered to detect statistical effects on patient-reported outcomes. However, we did see consistent trends toward improvement pediatric PROMIS scores, including a reduction in pain intensity and pain interference with p-values of 0.06, improvement in mobility, and reduction in fatigue. I want to highlight 2 instances of transformative improvements in mobility that occurred in our pediatric cohort. So this patient is a 13-year-old girl treated with conventional therapy for the previous 3 years. She lost ambulation at age 11, which is a typical course for a patient with severe lower extremity FD, and she had been a full-time wheelchair user since that point. By week 48, her mobility had dramatically improved. She was able to ambulate independently without any assistive devices. In this video, you can see her walking the hallway and navigating turns confidently. She continues to have lower extremity deformities and a waddling gait consistent with her skeletal disease. However, just a transformative improvement. So this patient was a 7-year-old girl who had been treated with conventional therapy for the previous 5 years. She has never ambulated. At baseline, she was unable to tolerate any weight bearing on her lower extremities, and she required full-time wheelchair use and full assistance with transfers. By week 48, she had progressed to training with a walker. So again, you can see with her feet placement, evidence of her underlying skeletal disease, but just overall a true transformative improvement in mobility. So in a small trial like this, outcomes can be challenging to quantitate, particularly things like mobility. However, from my clinical experience with years of caring for children with FD, I have never seen ambulation gains of this magnitude. In our adult cohort of 5 patients, we did not observe any trends in PROMIS scores, and we didn't see any substantial changes in mobility. We wanted to include a qualitative assessment to help us understand the potential impacts of Burosumab. We developed a questionnaire where patients were asked to select 3 activities of daily living that they felt were impacted by their FD. At weeks 24 and 48, they then rated how that impact had changed. Here are some of the activities that our patients chose. As expected, many were related to ambulation, like walking, using stairs, and transferring. Others were more individualized. One of my favorites was from a patient who has very severe FD, and she said that it really impacts her that she can't carry both her coffee mug and her purse at the same time when she moves between her car and her office. And then just given her bone pain and her skeletal involvement, having to make those trips 4 times a day really impacts her. So I think it's a great example of how these types of qualitative questionnaires can give us insight into our patients' experiences. We were encouraged to see that Burosumab was associated with improvement in these activities. In these graphs, the black squares indicate either much or very much improvement, and you can see that there was a progressive increase in this proportion over 48 weeks of treatment. 9 out of 12 patients had treatment-related adverse events. The most common was injection site reactions, which were mild in character and did not result in treatment discontinuation. 6 patients experienced at least 1 episode of hyperphosphatemia. All of these episodes were mild and all resolved with dose adjustments according to our treatment algorithm. Again, none resulted in treatment discontinuation. We did not detect any adverse effects on lesion activity. There were no changes in sodium fluoride PET-CT. We had 4 biopsies from adult patients, and none showed changes in the cellular density or proportion of fibrous tissue within FD lesions. So Burosumab treatment in patients with FD was well tolerated and associated with improvements in serum phosphate, alkaline phosphatase levels, and patient outcomes. So this supports using Burosumab to target a high normal phosphate level as a safe and effective treatment strategy in patients with FD. And I just also wanted to close here with an entreaty to all of us here as members of the FD and rare bone community that extending Burosumab use to patients with FD needs to be a key priority. Burosumab has been transformative for patients with X-linked hypophosphatemia and tumor-induced osteomalacia. It's an extremely effective, safe treatment that has transformed the landscape for patients with those disorders. However, compared to XLH and TIO, patients with FD and hypophosphatemia present with an overall higher degree of physical disability, in large part because FD onsets during childhood and persists throughout the lifespan, and also because the underlying dysplastic bone has higher vulnerability to the effects of low phosphate. So given these important risk factors in FD, Burosumab presents us with a critical opportunity to fill a large unmet treatment gap, prevent disability, and transform patient outcomes in FD. So while I'm very encouraged by the results of this trial, I have serious concerns about the ability of patients with FD to access Burosumab. There are a number of critical barriers, including the very high cost of the medication. Other barriers include investment of the pharmaceutical industry in rare diseases like FD. I'm very grateful for the support we received from Ultragenyx and Kyowa Kirin in conducting this trial. And I understand that Kyowa Kirin, who currently holds the rights to Burosumab in most of the world, has very generously offered support for this conference, which we're really grateful for and is wonderful to see. However, as far as I'm aware, Kyowa Kirin has not yet determined if they will seek regulatory approval for Burosumab in FD. I'm very hopeful that seeing the outsized benefits that Burosumab can have for patients with FD compared to the other conditions that they've sought approval for will help convince them, and that they'll stay invested in our community. It's important that we advocate not just to our industry partners, but also to healthcare systems and other clinicians to improve awareness about the benefits of Burosumab and FD. Hopefully, making the results of this trial available in a peer-reviewed publication will help with that. I also hope that the community that's attending the conference today will be a big part of advocating for the accessibility of Burosumab for patients with FD. So I'll close here with this picture. It's one of my favorite ones. This shows 3 of the patients from the Burosumab trial that were here at the same time for one of their study visits. Their parents spontaneously took this photo of them outside of the NIH Children's Inn. I received this picture from one of the moms in a text along with the following message. Dear Dr. Boyce, we wanted to thank you and your team for everything you're doing for our kids. We're so grateful to be in this study. It gives us hope for a better future. So to that I'll add, trials are great, but by themselves they're not enough to preserve that kind of hope. We've got to combine them with advocacy and with investment from our industry partners so we can make these treatments accessible to the whole community of patients who need them. So thank you all very much for your attention.